Second, cancer risk up to 40 years after treatment of Hodgkin's lymphoma. Hodgkin's lymphoma is a type of lymphoma which is a blood cancer that starts in the lymphatic system, and here is the first video to explain it.
The lymphatic system is part of the body's immune system. The lymph nodes throughout the body are connected by a network of lymph vessels. Lymph is a fluid found within the lymphatic system that contains lymphocytes, infection-fighting white blood cells. In the nodes, bacteria and other substances are filtered from lymph before fluids are returned to the bloodstream. One type of white blood cell is called a B lymphocyte, or B cell. B cells are responsible for making antibodies to fight infection and remembering the dangerous antigens if they appear again. Hodgkin's disease, or Hodgkin's lymphoma, is a type of cancer that develops in the lymph tissue. The cancer cells in Hodgkin's disease are called Reed-Sternberg cells. It is believed that Reed-Sternberg cells are a type of cancerous B cell. As the cancerous B cells begin dividing and multiplying, they form a tumor. This type of cancer interferes with the body's ability to fight infection. Symptoms of Hodgkin's lymphoma include swollen lymph nodes, fever, night sweats, lack of energy, and unexplained weight loss. More than 75% of all newly diagnosed patients with adult Hodgkin's lymphoma can be cured with combination chemotherapy and/or radiation therapy.
And here is also the second video to continue the explanation of the Hodgkin's lymphoma.
Lymphoma is a term used to describe lymphoid neoplasms that arise as discrete tissue masses as opposed to widespread involvement of the bone marrow, as in leukemias. Within the large group of lymphomas, Hodgkin's lymphoma is distinguished from all other forms due to distinctive pathologic features. This cancer is one of the most common cancers of adolescents and young adults, but also has a bimodal age distribution as disease incidence again increases with age, while non-Hodgkin's lymphomas, NHL, frequently occurs at extranodal sites and spread in an unpredictable pattern. Hodgkin's lymphoma is typically localized to single lymph node or a chain of nodes and spreads first to contiguous lymphoid tissues. Hodgkin's lymphoma also has distinctive morphologic features, particularly characterized by the presence of neoplastic chain cells called Reed-Sternberg cells. Reed-Sternberg cells release factors that induce the accumulation of reactive lymphocytes, macrophages, and granulocytes. These cells have a characteristic appearance with two nuclear lobes, large inclusions like nucleoli, and abundant cytoplasm. These cells have an owl's eye appearance and have a characteristic immunophenotypic include CD15 and CD30, while negative for other B cell markers. In the majority of Hodgkin's lymphomas, the neoplastic Reed-Sternberg cells are derived from germinal center B cells. Hodgkin's lymphoma commonly presents as painless lymphadenopathy, often in the mediastinum. Patients with disseminated disease are more likely to have constitutional B symptoms such as fever, night sweats, and weight loss.
Then we're going to talk about the treatment. Treatment is a combination of chemotherapy and high-energy radiation therapy. It increases the risk of subsequent malignant neoplasms and other late effects considerably. And here is a video to explain this.
I'm very much looking forward to hearing the discussion on CAR T cells in relapsed refractory lymphomas. CAR T cell is a very exciting area, very novel technology, very innovative technology, using genetically engineered T cells to attack cancer cells. In some conditions, like ALL, they seem to be very, very active indeed. Diffuse large B-cell lymphoma, though, which really does represent our main area of unmet need, particularly when it's relapsed, the data, I think, is less clear. So there are high response rates, but perhaps the complete response rates seem to be less good, around the 30 to 40% mark, and it really seems to be those complete remissions that are durable. There are also toxicities associated with particularly the anti-CD19 CAR T cells, such as neurotoxicity and also cytokine release syndrome. So I think it's going to be a very interesting discussion weighing up the pros and cons of CAR T cells with, for example, these very active new ADCCs that are around, which are probably easier to deliver to patients. The other factor in CAR T cells, which we haven't really seen yet in the UK, but they are starting to see in the US, is the cost. You know, they are looking like they're extremely expensive, not surprisingly, due to the amount of development that they're going to take to get them into the clinic. So yeah, I think the CAR T cell debate will be a good one.
Then we move to chemo and radiation treatments. Chemo is the use of drugs to fight cancer, and radiation uses high energy rays to kill cancer cells. It's given along with chemo most of the time. But it also has its pros and cons. The pros of this treatment will be that it kills the Hodgkin cells, and it also cures that type of cancer. And the cons, on the other hand, are also some of the side effects of this treatment, which is the hair loss, mouth sore, not feeling like eating, diarrhea, feeling sick to your stomach and throwing up, getting a lot of infections, getting black and blue marks and bleeding easily, feeling very tired, and also it changes your cells, which can develop in a second cancer in the future.
Patients with newly diagnosed advanced Hodgkin's lymphoma are often treated with one of two chemotherapy regimens, ABVD or BIACOP. These regimens have been associated with similar overall survival. However, several recent studies have suggested that BIACOP might have 5 to 10% increased survival at 5 years, at a cost of substantial increase in toxicity. ABVD has few long-term toxicities. although pulmonary toxicity from the bleomycin affects about 6% of patients. Biacop, on the other hand, is a more intensive regimen with long-term toxicity that affects nearly every patient, including infertility, fatigue, and future risk of cancer. The current investigators explored the potential for adapting therapy by de-escalating treatment for patients with a good outlook and intensifying it for patients at highest risk for treatment failure. They designed a randomized controlled non-inferiority trial. Patients with newly diagnosed advanced Hodgkin's lymphoma underwent a baseline PET-CT scan, then 2 cycles of ABVD, followed by an interim PET-CT scan. Patients with negative interim scans were randomized to continue ABVD or to omit bleomycin in cycles 3 through 6. Patients with positive interim scans received Biacop. The primary endpoint was 3-year progression-free survival, with a pre-specified non-inferiority margin of 5%. After 2 cycles of ABVD, 937 patients, or 83.7%, had negative interim PET scans. 470 received ABVD, and 465 received AVD. 3-year progression-free survival for these groups was 85.7% and 84.4%. The remaining 172 patients, or 16.3%, who had positive PET scans, received Biacop. Their 3-year progression-free survival was 67.5%. These results did not meet the pre-specified non-inferiority margin because the upper limit of the 95% confidence interval for the difference between ABVD and AVD was 5.3%. However, the omission of bleomycin after a negative interim PET-CT scan led to reduced pulmonary toxicity without evidence of reduced efficacy. Full trial results are available at nejm.org.
Then we have the second cancers. Women who have had chest radiation, especially before age 30, have been found to have a higher risk of breast cancer. Radiation to the neck has been linked to a higher risk of thyroid cancer, and also the radiation to the chest has been linked to a higher risk of lung cancer. And here's a video so you can understand the second type of cancers that you can get after treatment.
Treatments for Hodgkin's lymphoma have a high cure rate, but survivors have historically been at increased risk of secondary solid cancers. In a recent study, the authors asked whether the kind of treatments that have been implemented since the late 1980s, with lower radiation doses, smaller radiation target fields, and less toxic chemotherapy, have had an impact on the risk of a second cancer. The study assessed nearly 4,000 patients with Hodgkin's lymphoma who had survived for at least 5 years, and included cohorts of patients who were first treated in various periods between 1965 and 2000 at 7 academic medical centers and hospitals in the Netherlands. Patients were 15 to 51 years old at the time of treatment. About 60% of them had received combined chemotherapy and radiation. With a median follow-up of about 19 years, the risk of a second cancer was found to be more than 4 times greater in the patients with Hodgkin's lymphoma than in the general population. More than 1,000 second cancers were diagnosed in about 900 patients. This risk continued to be elevated even 35 years after the initial treatment, and by 40 years, nearly 50% of the patients had a second cancer. The data indicate that changes over time in the treatment of Hodgkin's lymphoma did not reduce the risk of second cancers. Notably, the risk was not lower in patients treated in the most recent calendar period studied, 1989 to 2000, than in patients treated in earlier periods. Thus, despite changes in the delivery of radiation therapy and a decrease in the use of alkylating agents in chemotherapy, an elevated risk of second cancers persists for patients with Hodgkin's lymphoma.
Finally, in conclusion, the treatment is aggressive and it can modify the cells which will produce the consequences mentioned before. People with this type of treatment should check monthly with their doctor to prevent it. It's a type of warning for the patients which have this type of condition. Thank you.